So now we're going to start our debate. So Dr. Shimer, you can take a seat up there. This is Dr. Bayan Aghdasi, who is a class of what, 2019? 2019. And this will be our spine debate. So just rules of engagement here, okay? You have 6 minutes to make your point, and you're welcome to take it as far as you want to. You're full mentor. So just put in perspective, Dr. Shimer inspired Bayan to join to do spine surgery. So it's pretty impressive that he's back here to take on his mentor. So 6 minutes. I will literally stop you at 6 minutes, and then after the debate, we'll vote. All right, good luck, everybody.
Morning, everyone. Thanks for having me here, Dr. Shimer. Thank you for inspiring me and for all the faculty for supporting me when I started. Guys, open versus MIS spine surgery. This is a no-brainer. There's no questions here. Open surgery. What do we do in open surgery? Make an incision down the middle of the back, pull all the ligaments and muscles off, expose the bone, get so far lateral that you can actually get a lateral to medial pedicle trajectory, right? Now you're looking at the whole spine, visualizing all of its anatomy, and then you're going to decide what to do. I just personally, intuitively, I just don't think this is the best we can do. In the age of AI, we need to have better solutions, right? Who amongst you would be willing to subject yourself to this kind of treatment? So not only that, we got PJK. So now you've totally devitalized the posterior muscles. It's going to fracture. They say about, that's the scar tissue, 3 months or a year after surgery. PJK rates as high as 40% at 1 year, 70% is in 3 years. Multiple studies, 1,000 patients in this adult deformity study showed a 70% PJK rate. The cascade of escalating fusion constructs rising up the spine. This is a pandemic. We need to get ahead of it. Okay, this is a new era, a new age of AI. We've got to find new solutions, right? There's a new standard of care in every field of medicine. We have TAVRs, we have endovascular work, we have robotics and Da Vinci's. What are we still doing with these big, wide open exposures? We've got robots doing things, for Christ's sake, okay? So listen to the anatomy. The anatomy is going to teach you how to approach it. When you look at mammals, their ventral surfaces are soft, they're pliable, they heal well, they don't get infected. There's no muscle. At L5S1, the aorta and the vena cava bifurcate right above L5S1. Just do an A-lift, make a little incision, reduce a grade 2 spondy, perk the screws, send the patient home the same day. Look at this incision on this lady. She went home the same day, radiculopathy resolved, back pain gone. These are my perk incisions, okay? So we have an augmented reality system. I have a tower with a drill. It's got the driver, it's got navigation, it's got augmented reality. This is what I'm looking at. I'm looking at the skeletonized spine with augmented reality. I don't need to skeletonize it in real life. I can use technology to see all of my anatomical landmarks, right? So you go back and now all I have are these perk incisions, no muscle devitalization, multi-level lumbar reconstruction. Patient goes home within just a few days. You can even do revision surgery, right? Anatomy is driving our goals again. You have a multi-level T-lift flat back. I pulled out the old hardware for mini Wiltse incisions. I put a prone lateral cage at L2-3. I used navigation to put screws above those prior fractured screws. I even did iliac perk fixation below, and I slipped the rods through the towers, okay? So now we have a MIS deformity and SI fusion for good measure just on that right side. All right, what about big constructs? L1 through 3 reconstruction, L4-5 reconstruction. How do we approach this? This is the lumbar scoliosis. Approach on the concavity, avoid the lumbar plexus, clean the annulus, and move the psoas posterior. It pulls the plexus with it, right? You're using real-time saphenous neural monitoring. I know if the plexus is starting to feel it. You slip your lateral expandable cages in. Look at the amount of lordosis we got in this. No osteotomies, no PSOs, massive reconstruction, bring her back for an A-lift at 6 weeks, right? So we had a 40-degree coronal curve, arrow rocket straight, okay? Moving down. Now we would have rigid deformities. Rigid deformities, how do we approach this? Our trick with the laterals is good for the coronal plane, but what do we do when the facets are locked? Drop a tube, do a double barrel, MIS T-lift, drop some expandable cages in there, and you'll straighten that rigid deformity out as well, okay? Now, what if you just want to do a one-level perk, a high crest, plexus in the way? Okay, MIS T-lift, pedicle-based retractor system, expandable cage up front, AR navigated screws in the back. Look at that result. All right, MIS tubes, we all know, microdiscs, drop a tube, 22 millimeters, pull the disc out, send the patient home. What are we not talking about? We're not talking about stimulators and kyphoplasties and laser disc institutes. Those are all scams. We're talking about real reconstructions with lower EBL, lower length of stay, lower infection rate, lower revision rate, less narcotics, less cost. I'm not even getting into sacroiliac fusion, endoscopics, arthroplasty, or DTRAX for posterior facet work. That's a whole other talk of MIS in the future. You can see some of these x-rays are pretty nice as well. So MIS expands the indications. You can access a wider group of the population, sicker, older folks, get them moving quicker and out of the hospital sooner. In conclusion, Dr. Shimer, I owe everything to you. Dr. Shen, that talk was absolutely amazing. I went to fellowship at Hopkins and I've never seen a posterior cervical corpectomy. Thank you guys for having me.
Fine, you can see one with a minute to spare. That was 65 slides in 5 minutes. There you go. All right, have a good luck.
I wish I'd had access to your slides beforehand, so I could have prepared better, but that was excellent. Thank you so much. And, you know, I just want to take some of my 6 minutes here as I watch you take away to say how kind of neat this is, to see everyone come back and to see not only the future of orthopedics, but the history and what I certainly owe a lot of what I've been able to do to take care of patients. And it's great to battle Bayan. So we're going to talk about, I also think it's amazing that Frank Shen can do that type of surgery and can't figure out a pointer. As I sit here and struggle with the pointer too. Hold on, this goes to show you my age. All right. So it's there's supposed to be audio here that plays the theme for. Yeah, exactly. He's got it. So I think those were all very compelling points that Bayan made. But I first want to give some disclosures. I do get some royalties from NuVasive or what was NuVasive, now Globus, and I'm a consultant for Medtronic. And in fact, technology of Medtronic called Mazor, which is interesting because my biggest disclosure, about 80% of my practice is MIS spine surgery. So I'm actually not going to argue for superiority of open spine surgery. In fact, I'm going to argue for non-inferiority of open spine surgery, well done open spine surgery. So to just go through my talks, I'm going to talk about rules of engagement. Dr. Gwathmey talked about it, but I have my own rules of engagement. And I'm going to talk about definition. What's in a name? What is MIS spine surgery? What does it mean? And Bayan, I think his slides are like he practiced as a resident, like everywhere, right? Like he's in this room, he's in 2 rooms at once, and that's what his slides felt like. How about some research? You know, I want to talk about the lamppost. We as orthopedists use data like a drunk uses a lamppost, right? More for support than illumination. I know it's been said many times. And I want to talk about the hustle of spine, right? I mean, part of this is an advertising component of spine, and are we really doing our best for patients by talking about the superiority of MIS spine surgery, and where does that leave us? So rules of engagement, nothing ad hominem. Right? Bayan was a gentleman. The only thing I want to remark on is how loosely his suit jacket and shirt is fitting him. And I was thinking today, I'm looking forward to seeing Bayan. I don't know if it's one size up in the wardrobe or more time in the OR, not allowing you to get to the gym. So nothing else. I already.
No overpowering for noir.
Yeah, exactly. And I want to argue that there's good MIS spine surgery, no doubt about it. There's bad open spine surgery, but the vice versa is also true. I think there's bad MIS spine surgery and there's good open spine surgery. And the foundation remains shared and is not in dispute, right? You want to make the correct diagnosis. You want to demonstrate failure of optimal conservative treatment. You want to have a well-reasoned, expertly performed surgical procedure that addresses that pathologic target. So what is minimally invasive? I didn't even need to put this slide in because Bayan just went through all of it. But, you know, I would just say, let's just take a case, for example. So we have a 4 or 5 degen slip. The facets don't have a big effusion. It doesn't move much on flex X view. So how do you treat this? Do you do an MIS T-lift and you have to use fluoro or nav or robot or augmented reality? Wear those goofy goggles in the OR. Use an expandable cage. Use biologics. These are expensive technologies and implants. Do you do an anterior lumbar body fusion? If you go trans-psoas, you go in front of the psoas, you go behind the psoas, you want to monitor what company are you going to use? Do you use perk screws? How about a mini open incision with cortical screws? Can I advertise that as MIS? Sure, right? Because, you know, a centimeter less than my open incision. Or how about the most minimally invasive of all procedures? What about a decompression, right? You showed a lot of metal in there. I would argue decompression. So what is minimally invasive? So this is Supreme Court Justice Potter Stewart. He said, I know it when I see it. He wasn't talking about MIS spine surgery. He was talking about hardcore pornography. But, you know, it's the same concept. So the research, I'm not going to blast you with a million studies. I'll just show you a couple well-done studies. But really, what journal do we all look to? This is what AI will do for you. I said, make a fake journal that says the Journal of What I Like to Do Medicine. You know, it missed a few letters, but this is what we do, right? I mean, we pick some studies, but I say, I like to do this technique. So this is the journal I read. Frank and I talk about that all the time. That's the journal we read. So, you know, this is a New England Journal. It wasn't specifically looking at open MIS, but it did, in post hoc analysis, look at that comparison and showed open surgery had fewer reoperations. And the groups did the same at 2 years, exactly the same. That's New England Journal. That's not open source OTA International. So this is looking at open versus MIS, similar outcomes in pain and function. MIS had a higher pseudoarthrosis rate. Tubular retractor. This is a group in the Netherlands that was focused on doing tubular discectomies. They had a higher complication rate and worse outcomes. So this is what really concerns me the most. Every day I'm hustling, right? So if I have this word association, where do all the words go, right? So I'd say elegant, thoughtful, quicker recovery goes in the MIS, high tech. Look at all those other terms, right? So that's what they're going to use against me. Oh, it's brutal and can't believe all this. Look at this advertising. This is what it says to patients. It says you're going to have less operation pain. You're going to have faster recovery. Look at this. This is the Laser Spine Institute and the Bonatti Institute. And look what happened to them, right? They're both out of business. So these groups are saying open spine surgery is dangerous and terrible and wrong, and they're taking horrible care of patients. So my final considerations is revisions. Midline incision's a workhorse. You can always revise it. How do we train people? Only on MIS. And if we train those residents and fellows only on MIS, what do you do when your tech goes down? Do you panic if your goggles fog up or if it doesn't work? You know, and does MIS bind you to an industry relationship, right? We want to maintain our position of power within the relationship with industry. Partnerships are important, but don't let the tail wag the dog. So, you know, MIS is not a monolithic religion. Winston wants to stop me. Come on, I have a little bit of seniority over. It's really a collection of surgical approaches, right? So you utilize all those approaches. A-lift, transpsoas, I like all those approaches, but there's no free lunch. MIS can go very bad. I actually have another talk on screws through the canal because the array got bumped and they drive all the screws through the canal. So, you know, this is 2000, you know, is open surgery the bone and MIS is like this high tech thing. I'll disagree with that. So thank you guys.
All right, that was great. So since Bayan finished early, he gives Adam a little bit extra time. So thank you guys. So he's gonna pull the slide up. Get your phones out, okay? Can you pull it up? And just see. So here we go. Oh, no, wrong one. The spine one. So back up. That's one for the next one. You got it? There it is. Oh, it says, yeah, there you go.
Yeah.
All right. In real time, too. Oh, God, this is terrifying. Okay. Oh, Bayan. Huh? Come on, residents. Oh, so I was going to give you guys 30 seconds to vote, but I think once we get up to about 50, I don't know how to do in the room. Oh, it's creeping up. It's creeping up. All right, let's call it. Congratulations, Dr. Adam Shimer, for winning debate number 1. Our second debate coming up right now, so we got to keep going. So this is really exciting because we're actually bringing Professor Emeritus on for this debate. But Scott Yang, who is actually in Brian Warner's class as well, is going. We're going to debate a pediatrics topic on spine as well. So very good, Scott Yang.
Engagement, Dr. Abel, we can't yell at.
You ready to go?
I'll try to figure this one out too. Let me just practice here.
I'll let you practice for 1 second and then I'll.
Yeah, okay, there we go. All right, so I'm gonna talk about fusion. Fusion is the way for idiopathic scoliosis. Dr. Abel will argue that this patient won't need a fusion. At the University of Washington, we love our Huskies. They're loyal, they're great runners, but the resemblance to Dr. Abel really doesn't stop there. It can be very difficult to argue with. They're restless, they're stubborn, and they have these penetrating eyes that look into your soul. So I know this is going to be a very difficult debate to go up with this man, but this is a 15-year-old female with adolescent idiopathic scoliosis who's 3 years postmenarchal, essentially skeletally mature. She has a 50-degree right thoracic and 53-degree left lumbar curve. My charge is to say that posterior spinal instrumental fusion is the way forward for her, and she will do much better with that rather than letting this go and do physical therapy. So why should we do surgery? I know we can all hear Dr. Abel saying step away from this child, but the surgical risk for adolescent idiopathic scoliosis has gone down dramatically. We are getting much better at this operation over the past few decades. The incidence of major complications with this operation is very, very low. So I would argue we can step forward and do this for this child. This patient has an over 50-degree curve. We know from old studies from the University of Iowa natural cohort studies of over 40 to 50 years follow-up that patients with 50-degree curves at skeletal maturity will continue to progress after they're done growing. So this patient will have a larger curve as time goes on. The answer as to whether a larger curve, especially in the thoracic spine, leads to cardiopulmonary related morbidity or mortality is still unclear. The small cohort from the Iowa study didn't really clarify or didn't really prove that it has any major effect on mortality. But we have to remember that these old studies have half their cohort missing. Half of their cohort was not lost, not found, or unable to be contacted. So we don't really know the true mortality rate for these patients. We know that patients with over 60 degrees thoracic scoliosis, many of them have a forced vital capacity percent predicted of less than 75%. So if we take a big United States population of over 50,000 patients, whether that not including necessary scoliosis, but restrictive lung disease with restrictive spirometry, we know that their 20 years hazard ratio is around 2 for mortality compared to a non-restricted physiology. So we know if we take a bigger population, maybe there's a correlation there as well. So this patient will continue to progress. 50 degrees, she will continue to get larger and larger as she ages. Dr. Abel may say that if you place instrumentation into the mid to lower lumbar spine, as will be required in this patient who has a thoracolumbar curve as well, you may get accelerated disc degeneration. This may lead to early wear in a 16-year-old that's not starting life in a good spot. But there are studies that show if you look at more than 10 years follow-up after posterior spinal instrumented fusion, that the disc degeneration is really agnostic to the lowest instrumented vertebra. You can do a fusion to T12 or L3, and the vertebra adjacent to it is not necessarily correlated to where you stopped, but more so your age. So we can't stop aging. So don't withhold the fusion on this child. This patient's going to get disc degeneration anyways if you did nothing. So patients with a thoracolumbar lumbar curves, like this patient also has, will have a higher rate of disc degeneration if you did nothing. So I would argue we're not causing any harm in terms of the discs if we did posterior spinal instrumented fusion for this patient. This patient also will have a higher chance of having back pain than a normal population. We know that also from our natural history studies. I know Dr. Abel thinks, if you're not tough, then you shouldn't be doing this. But, these patients will have a lot of pain. And even though these don't have validated health-related question of quality of life surveys in these old studies, we have newer studies that show if you compare untreated scoliosis to a non-scoliotic patient population, validated questionnaires demonstrate that these patients do poorer than untreated scoliosis. So Dr. Weinstein himself, 40 years later, for his cohort 40 years later, he said that about a third of his patients felt that their life was limited due to scoliosis. These are untreated scoliosis patients. They had difficulty purchasing clothes. They had decreased physical activity, self-consciousness. And The seniors today, it's different from the 1940s cohort. These patients may be doing this, they may be much more different demands. And, we can see that seniors really enjoy their lives these days. And we really have to think about, how important it is to self-consciousness. So let's give this patient the best option because things are changing with time too. So she's an athlete. You may say, okay, you're going to fuse her to L3 and L4. She's not going to be able to play sports, but we have data that shows people, regardless of the lowest instrumented vertebra, can return to any sport. Dr. Abel himself showed that short-term and midterm outcomes after posterior spinal instrumented fusion, patients do better than before surgery. If we go a little bit longer out, or 10 years out, we can see that compared to an untreated population, posterior spinal fusion is also favorable in terms of quality of life domains. If we go further out, 40 plus years from Harrington rod, we can see that there's equivalent quality of life measures compared to a non-scolioid population, which is interesting because it seems like the older we get, it's not so much that the fact that you had a spinal fusion that leads to quality of life differences, more so age or other things. So I would say we should do what's best for this child. She'll be fine with the posterior spinal instrumented fusion. This is her, and you can see that she can still play baseball. She's gonna try to go to college, play softball, and she's gonna do just fine. Thanks, Dr. Abel.
But that social media is dangerous. Quit that stuff. Well, I'm glad that Adam preceded me because talk about the lamppost as support versus evidence. You did a lot of that, and I'm going to show that. So this is the case that we're talking about, a 15-year-old young lady with two 50-degree curves, right thoracic, left lumbar. She's mature, Risser 4, Sanders 6. And whether she should have surgery now or observation. And I'm going to make the argument, see if I can figure this one out. Is it the up or down? That observation is the correct way to go for this young lady. So I'll present this like I would because, in my practice, I saw a lot of kids for second opinions. They go see Dr. Young and they come to me, Mr. and Mrs. concerned about their daughter innocent. And I have to tell them, no, your daughter does not need surgery with fusion and instrumentation. The scoliosis of this magnitude does not have serious health consequences. Her trunk and shoulders are balanced and a trunk alignment is well compensated. Furthermore, its growth is the engine that drives progression. And innocence has very little growth left. You can see from the chart the growth velocity on the y-axis and her age that she's at the end of her growth. Your daughter currently has no activity limitations and she can run, play, in sports. But if you think that instrumentation and fusion will help that, you're wrong. It's going to limit her trunk motion and will limit her functional capacity. You'd have to drink the Kool-Aid to think that that long fusion, she can swing a bat as well or run as well. So when you see this kind of thing, they don't move as well. And this, I know we're orthopedics, but let's be honest. So if you have any hesitancy, Mr. and Mrs. Concern, your daughter should be observed and begin a program of maintenance therapy, including flexibility, core strengthening, and aerobic conditioning. If she sticks to that, a little bit of back pain that she has will get better. Plus, you avoid the 6 to 10% risk of reoperation for painful implants, decompensation above or below the instrumentation, infection, and neurologic injury, which still exists. Of course, there will be adjacent level degenerative disease, despite what Dr. Yang has told you. So let me emphasize the rationale for my recommendation. First of all, progression after skeletal maturity is nonlinear and unpredictable. The Weinstein studies, again, these were cross-sectional studies with patients lost to follow-up throughout. And if you interpret them the way they should be interpreted, you can see that they are unpredictable, the progression rate. The evidence that functional outcomes are better from surgery are just not available. the study that Bayan did with me shows, of course, we have to frame it that way because we're publishing in orthopedic journals that this is great, but the reality is there's very little difference in the functional outcome. And the longitudinal studies suggest that cosmetic concerns that teenagers have get less with time. What they care about is their quality of life, getting married. And when you look at quality of life surveys comparing matched people without scoliosis compared to patients with scoliosis, they're very equitable. Furthermore, I have the empirical wisdom of age that's just shown me that many of these kids don't do so well after fusion, and they often end up with pain. Now, that's not to say that there aren't several advantages for surgery and instrumentation. You do stop the chance of progression. There are complications, but you do stop the chances of progression within the instrumented vertebra. It's a very fun procedure, no question about it. And you do have very impressive X-ray changes. I think that all those screws and things is awesome. The monetary reimbursement is excellent. And after she turns 18, you can turn her over to Dr. Shimer and the adult surgeon. So you don't have to worry about all the late complications from the instrumentation. Innocence should continue her activities, engage in a physical therapy program, and return in 6 months for radiographs. Thank you.
All right, lit it up. All right, 30 seconds. The other one, here we go. Ah, what a truth. Uh-oh. It's kind of fun. We're back and forth. All right, we're gonna use a clock on this one. 14 seconds, okay? I think you guys are still afraid of your faculty. 6 seconds left. 5, 4, 3, 2, 1. Great. Congratulations, Dr. Abel.
Thing on the BlackBerry every 30 seconds. You guys remember this, like BlackBerry that never left his hand? This entity is also known as Chhabritis or Chhob throb. The picture and the diagnosis are courtesy of your program director, Winston Gothamy. So I was, good little resident, learned from the master, and Dr. Chhabra inspired me to go into hand surgery. So I ordered everything to him, but he taught me this crazy LRTI technique. So you harvest the FCR through a bunch of incisions on volar forearm, then you got to pass it up through the dorsal incision, then you got to drill through this the thumb metacarpal base, but don't break the bone bridge, and then you got to pass this tendon through, which I found to be like the hardest part of the case. Then you got to sew it deep to itself, deep in the wound, and then sew the snot together into an anchovy. I did that for the first 6 years of my practice, and I found during practice that a lot of the thumb metacarpals were subsiding. I would back them up with a tightrope. So I started adding that to it, and the little old ladies hate this because like the little metal buttons on the outside, they can feel them and annoying. So this case ended up taking me like 2 hours to do. And, there's another LRTI technique where, you pass the APL graft through 2 bone tunnels over the ECRL, under the radial artery, so to the FCR. I mean, I can't imagine like what exposure that requires or how much time, but, this is just like frustrating. So looking at some literature, I'm not a big, academic kind of guy, but, looking at some of the literature, it's this 2009 randomized controlled trial, trapeziectomy versus the FCR-LTI, really no difference. This was a Cochrane review from 15, looked at a bunch of different thumb-based arthroplasty procedures. Again, no benefit of LRTI versus trapeziectomy alone. This paper from 2019 was looking at suture suspension technique where you sew APL to FCR deep in the wound and kind of make a little hammock under the thumb metacarpal. Big takeaway with this was that LRT takes a long time, so, it takes a long time in the OR. Suture suspension is, yeah. But also, the thumb metacarpal, would migrate proximally with an LRTI fairly similar to just a trapeziectomy alone. And the suture suspension was much less of the proximal migration. So then this paper from 2023, suggests that, some immediate stability of the thumb metacarpal makes a difference. So in early rehab and, less subsidence and improved DASH score. So, patients are non-compliant. They, don't listen to what we say in terms of activity restrictions. So they need some immediate stability of that thumb metacarpal. So, however, I was a little hesitant to just rely on suture alone because, it's going to fail eventually. So I was looking for some immediate stability with suture, but some biologic in there for long-term durability of the construct. So I abandoned my training and made Dr. Chhabra very mad. Look at these. Angry Chhabra. So I went with the KISS principle of keep it simple, stupid, but I would never say stupid to King Chhabra and his gleaming castle on the hill. So I went with this internal brace construct. So it's anchor in the thumb metacarpal base, anchor in the index metacarpal base, suture suspension for immediate stability, and then with a graft in there as well for long-term durability. So that made me happy. I was liking that. So this is briefly how it goes. So you take a slip of the APL, the APL has a ton of slips, and usually you can find one that's about 2 to 3 millimeters, perfect for the graft. Whip stitch either end, load it into the swivel lock with a suture tape, drill into the index metacarpal base and the thumb metacarpal base, and then you make this nice little hammock for the thumb metacarpal base right there. So these are just some pictures I took last week of a case I did. So it's incredibly difficult to take pictures during surgery with your loops on, but so sorry if they suck, but due to this little volar Wagner incision, so volar, you stay away from the radial artery more dorsally. That's nice. It's nice too because you're looking straight down the saddle of the thumb metacarpal, and then down deeper you can see the trapezoid and scaphoid in the FCR. So drill tunnel, graft, and suture tape, and so that's the final construct there. So, Chhabra, I love you, but you're wrong.
All right, thanks, Scott. I'm not going to disagree with you. There are other options. So I'm going to say, follow up on what Coach O'Connor said. You got to stick to your fundamentals and you got to stick to your principles and you got to stick to your foundation. Doc McHugh and Greg Degnan taught me how to do this operation. And I've done more. I do 125 of these a year for 24 years. I mean, your experience is nothing compared to mine. Okay? It's one of my most common operations. I'll do 4 of them in a day. Average time, even Lawal did it in 40 minutes or less. And he's a spine surgeon, okay? This does not take long if you're good at it and you have experience and you follow your outcomes, okay? So that's important. So let me just kind of, before I humiliate you too much, I do want to talk about Scott a little bit. He's a Nittany Lion. He did his med school here. One of the most talented residents I had the opportunity to work and train with. He was in the Air Force, did his hand fellowship in Allegheny. He's up at State College in practice. But he's a true hero. So we're very proud of our graduates, but he did 2 tours of duty, Afghanistan 2011, Iraq 2017. And he was presented with a Bronze Star for meritorious achievement while assigned to the surgical teams deployed there. Remarkable guy. Remarkable surgeon, and he's served our country in a way that many of us have not had the opportunity to. So thank you, Scott, for all you've done. But now I feel justified in insulting you. So trapeziectomy was done by the British. You know, we're in a fight with the British now, right? We're apparently with tariffs, but trapeziectomy with LRTI was popularized by American surgeons, and Pellegrini and Burton, who were 2 of my mentors, really popularized this, and they were at Penn State when they did this. So just so you know, at Hershey. So it's not that hard of an operation. The incision's not that big. It's not hard to make bone tunnels if you're good at it and you're a talented surgeon. And it's not hard to pass the tendon either. It doesn't take long, and there's different tricks to do it if you had paid attention when you were a resident. So, and the accordion is one of the most fascinating things you can do. That's why I went into hand surgery. When I saw McHugh and Degnan do this, I'm like, this is one of the coolest operations I've ever seen. So outcomes, fantastic. They do very well for the most part. And just like anything in orthopedics, you have some outliers, but overall DASH scores are great with LRTI. And much better than trapeziectomy alone. We all agree that trapeziectomy is not something that should be done. There are more pain scores with trapeziectomy alone. Functional strength is better with LRTI. And there's no real differences, however, trend to lower DASH, which is better in LRTI cohorts. What about suture button suspension plasty, which was mentioned? There's a lot of positives for this. Avoids tendon harvest, introduces implant-related complications with higher costs associated with implants. These little sutures things are expensive. My cost is much lower than my partners who also do this. If you look at the monthly report we get, my cost for this operation is minimal because we're not using implants. Some of these implants, like the tightrope, bother patients and they fracture. You can fracture the metacarpal, index metacarpal. So, and you still get subsidence with even these suspension plasties. Subsidence is not always problematic. Suspension plasty is not better than LRTI. There's studies out there that have shown that there's no difference, but the cost of implant is significant. And if you own shares in a surgery center and you get revenue from a surgery center, you may want to think twice about using implants. You know, I remember when one of my partners who left here asked me, this is when locking screws came out, and he said, are you using locking screws? I'm like, yeah, we're using locking screws. He goes, we're not, because it's cutting into our revenue from our surgery center. So we just put cement in the hole and drill a regular screw in. So I'm like, for a wrist fracture, that makes no sense. But so, you know, I always tell everyone, trust the boss. I've published extensively in this area. I did a literature PubMed on you, Eisenhuth 0. And I also treat, you know, I know how to treat failed because I have the algorithm that is used around the country on when you do have failures with trapeziectomy, suspension plasties, LRTIs. I will do suspension plasties as well. I'm not saying there's not a need for it, but I mean, trust the guy up top or this guy who's eating, you know, this is, I mean, I got to tell a story. I have time? Yes, I do. So Scott was on my service with Winston on a hand service. And this is when I was alone. And we found a way, despite how busy we were, to go eat at Belmont Barbecue on a regular basis. And then Scott had to lose about 30 pounds for his military, Air Force, what was it, training, physical, so you could like, you know, be in the military. And he started the hand block. And he's like, he kept saying, I gotta lose weight. And then we would go have a slop bucket, which was about 3 times a week, which is barbecue, mac and cheese, coleslaw, and hot sauce in a styrofoam cup. So I think he gained 20 pounds on the hand service. So I didn't help him from that standpoint. But, you know, LRTI is the answer. Vote for a champion. And Dr. Eisenhuth can drink a lot. So we used to drink a lot together too. So anyway, love to have you. Glad you're back here, Scott. And you really made us proud in so many ways. And I'm so grateful to hear how well you're doing and how well your family's doing. So.
There you go. Oh, you broke it. All right, so we'll give you guys some time to vote. Chhabra's got a ton of championship rings already, so he doesn't need any more, just by the way. All right. Is it active? You guys should just sit up there and watch this thing go and vote.
There you go, 100%. As expected.
All right, we'll do the 30 seconds now in case this gets
Buy a beer.
You break this thing. Oh, Bobby. 38. I think you can vote too if you want to, Scott, if you need to. Oh, we have 13 seconds, 10, 46, 47. The faculty seems to be kind of winning a lot of these. I think there's some type of voting issue right here. We'll have to look into that, Jalen. All right. Well, congratulations, Dr. Bobby Chhabra. Thank you, So we had to move the foot and ankle to the didactic portion tomorrow to accommodate Coach O'Connor since it got rained out. But we wanted to keep the debate today. So Joe, get this up there, by the way. So the foot and ankle debate will take place between Victor Anciano, who's class of 2020, who's now at the University of Louisville, versus Dr. Joe Park. So, let's work this thing.
Nope. Which one do you think? This one?
Just down.
Down and down. All right, so thanks everyone for having me. This is a topic that I enjoy, and I'll try to keep the facts minimum and the excitement more, since that's what matters here. But just a little bit of talking about the MIS. Many of you may not have heard of it, and many of you fall asleep just thinking about a bunion. So I'll keep it a little bit light and show you kind of like how I do this and how I got into it. So I'll show you the percutaneous technique, some of the challenges and some pearls I've taken away. I have some literature. I walk away. I have some literature to show you as well, but I don't want to bore you with that. So I kind of summarized most of it here. This is not a new fad. We have been doing this for many years. This has been going around since 1960s, where they were doing this just with K-wires, but then it lost popularity. And now ever since the mid 2000s to the teens, it started getting popularity again with some jigs and new screws that made it easier for people to do again. But overall, it has been shown to have less pain, less stiffness, lower wound complication rates, better cosmesis, and a quicker return to work. And this is all from multiple studies that have been coming out with this. So outcomes in the long run, very similar, open versus MIS. And what you have to decide is, how do you want your patients to feel the first 6 weeks of it? Most people come back from an open bunion saying this was the worst procedure, this was so painful to recover from, and then they're happy with the results. And that's what we see after 6 weeks, 3 months, 1 year, everyone's kind of happy where they are. But it's the initial time that really makes a difference with the MIS procedure. So I'll show you some of the pre, post, and what the wounds look like. So the early post-operative wearing really helps with helping with the inflammation and improves a lot with the post-operative swelling for it. Range of motion is great after. This is immediately the 2-week mark, almost painless completely for the patient while doing this at the 2 weeks, and they have no pain with that, able to start weight bearing. So I mentioned multiple studies have come out, not going to bore you with it, but they have compared different procedures from the open procedures. As we all know, there's a whole alphabet soup of open procedures that we can do. You do a scarf, you have chevron, Do you do proximal, distal? MIS has kind of revolutionized in that we just do one procedure to address all of the deformities. So multiple outcomes shown, 2 years follow-ups, 3-year follow-ups, 5 years follow-ups. They've seen multiple meta-analysis, and all of them showing really equal outcomes with doing it open, but just a really faster return to work, faster mobilization, and improved pain overall. So indication still a painful bunion, right? Don't operate on cosmetic bunions. But really if you're thinking for MIS, anything that's a flexible hallux valgus deformity, just no TNT arthritis or instability in radiographic signs. So usually when you're looking at your laterals, you know instability there. I don't really go a lot by the hypermobility. Sometimes we talk about to do a lapidus because we know that even for big IMA angles that would be considered for a lapidus before, we can do MIS bunions for those as well. And then just considering for the smaller bunions that your width of your iron space is not significantly smaller than your first metatarsal head because it becomes really hard to shift that head. These are kind of the usual implex, usual suspects that we use, multiple companies that are out there, but the screws are all very similar with some sharp cuts so they can really bury in the bone. And the setup in the OR is a little bit different than you would do normally. I usually have my foot floating off the bed so that you can bring in the mini C arm and do everything with your mini C that way. The setup very easy to set up for your techs as well. This is pretty much everything that you use throughout the whole procedure. You begin with an osteotomy or with your wires, depending on what you want to do, but I'll show you a little bit. You mark your wires, mark your osteotomy where you're going to be. It's very similar to your chevron, where you're going to have your points if you're doing a chevron osteotomy or if you're doing a transverse, and I'll talk a little bit about that. But the medial eminence resection that we usually do with our open procedures has fallen out of favor in MIS, and most people are not doing one anymore. And I'll show you some of the post-op extras of why not. But you can do that, and if you do, that will be your first part here. Your osteotomy, you're coming in from the medial side and doing dorsal and plantar with your burr and performing your complete osteotomy that way. Your burr trajectory is important, and this is where there's some failures with this. You can see that if your burr is angling one way, your head will move and elongate, versus if your burr is in a different angle, your head is going to do a different translation for it. So this is very important to keep in mind, especially if we're shortening afterwards or for some of the complications that can occur. So important to have a good technique for it. Transverse or chevron osteotomy. Initially, most people were doing the chevron. They've all moved to a little bit transverse because of the easy procedure that it is. And just breaking it down. So you do your osteotomy, you put your wires in, you shift your head, and you put your wires in for your screws. And then this is a year after for follow-up. So that osteotomy does fill in. The translation maneuver is important. You have multiple products to use to help you do it for that, and then jigs as well. So there's multiple jigs out there. Most companies have one. So whatever your comfort level is, I began training with them, but now I do mostly just wire alone and manual translation alone. The medial spike is what you have to take off, and you can see why that medial eminence is no longer important, but that medial spike is important to take off, and this is how you do it, using your burr as well, and you can go fish for it afterwards. And then your Aiken, you can also complete it through there as well. Lateral release is now an optional thing. You don't really need to do one, but sometimes for really severe deformity, it's not an unreasonable thing. Post-ups, everything looks great, really small incisions, patients like it, very minimal inflammation afterwards. Your dressing is very similar, but you don't have to worry about your bunion dressing anymore as much as we did before, okay? So you can address really big deformities and even do Aikenets as well. If you notice those two toes as well, afterwards just doing hardware-free Aikenets removals from that. So don't fear that shift. Don't fear that shift, that will fill in. I had some videos to show you, but for Luso's time, I'll just kind of show you so you see it's not that complicated. You kind of just have to trust the force when you're doing this and getting your shift aggressively with it. The last thing I did want to touch on is there are some complications that come with this. So I did want to show you that it's a very stable osteotomy, which is why we're able to have them walk afterwards. It really does not move, and they're able to weight bear immediately after surgery. Challenges, there's a learning curve to it. You can have some skin thermal injury, metatarsal shortening that we talked about, and the alignment of osteotomy. So these are some of my challenging cases that had non-unions and had to salvage afterwards. So, you know, you get shortening afterwards, but the rate of it is really small. It's 1 to 3% out there in the literature. So just because something is complicated doesn't mean we should stay away from it. I think this is the way to go about it. Thank you.
All right. Thank you very much for that great talk, Victor. I told you I'd keep it clean and respectful. So this was my title, Hallux valgus correction, why MIS might be a mistake. So these are my disclosures, none pertinent to this talk. Victor, graduate art program 2020 is my first assigned resident mentee. Those of you who don't know, we have a formal mentorship program. So obviously I'm very proud of him. He's from Venezuela, played soccer in college. So that a lot of good things going for him. He did a great fellowship at Ortho Carolina with a lot of our mentors here, people who have changed my career. And he's now in faculty, as he said, and part of the sports medicine team. So this is a bobblehead doll that Victor gave us when he finished. And truthfully, I'm really proud of him. So super proud. But things you learn when you get a little old and gray, nothing ruins a great outcome like long-term follow-up. Every surgery is an opportunity to be humbled. Patients are probably not as happy as you think they are. If you ask them, they'll tell you that. MTP fusion is a great salvage procedure and likely the best hallux valgus operation out there. And if you're honest, people start asking you to talk about managing complications, and that's something that happens as you get older. So quickly, this is the one slide I have for review, similar to what Victor said. The main thing, hardware removal, 6.2%, pretty reasonable complication rate compared to what we traditionally do open. But I will say in general, people don't like to publish about their complications. And right now, a lot of consultants and design surgeons are doing things. So just be cautious of that. So here's some of my cases. I don't want you guys to think all my cases go perfect or very well, but here are some ones that went okay. So 61-year-old female, severe bunion, IM angle of 20. And the way I reduce this, I close the forefoot with a S-mark bandage or a Penrose drain. And you can correct the rotation by putting a joystick or an olive wire in the base of the first. And here's what she looked like 1 year post-op. Quite an excellent correction. She was really happy with this. I'm not sure I could have done that MIS. 44-year-old female, former professional figure skater, IM angle of 24, very bad flat foot of 10 degrees. In her case, I did a MDCO, medial calc osteotomy plus the lapidus, and got this correction. Here's how she looked at 10 months post-op, and she did great. There's the pre-op in comparison. 45-year-old female, again, severe hallux valgus, IM angle of 19. Here's what that looked post-op. Again, did great. More simple correction, chevron Aiken, 52-year-old female, and she was very happy. So you can get great outcomes using the traditional techniques. You obviously have to be very diligent and meticulous about how you do things. Here's a 71-year-old female, severe deformity again, 19 degrees, bad midfoot arthritis. And here's an example of one, again, that I think turned out well, a tough surgery to do, but as you stay in practice longer, these are the kind of cases that get sent to you, not the simple bunion that you might wish that you get. And here's, again, the pre and post-op correction. Sometimes things don't always go perfectly, right? So 73-year-old female, horrible midfoot arthritis and this very bad bunion. And intraoperatively, I fused multiple joints, including the NC joints and TMT joints. And she went on to fuse all those joints. This was the correction intraoperatively. 6 weeks, I think, looked reasonable. She did go on to fuse all these joints. But 2 years later, again, long-term follow-up, now you can see she had pretty terrible soft tissue and her big toe started drifting over her second and was pretty miserable. So for her, you always have to have a plan B. So in this case, I went and just fused her MTP joint, and she's probably the happiest patient I've had in a long time. And MTP fusion you can do for almost anybody. So here's an 82-year-old female with a near dislocation of the first MTP, okay? And there's what that looks like. But complications can happen, as Victor said. Holly Johnson sent me some complications to go through. She does a lot of MIS. She's one of the world's authorities. 72-year-old male. Here's how it looked at 2 weeks. Excellent. Totally lost correction at 6 weeks. Didn't get an adequate fixation, okay? Here's another one. Looked great at 6 weeks. Here that is at 8 months, completely failed. And the problem is that the revision surgeries are huge. Requires bone grafting, taking all the hardware out, etc. Okay, so here's another complication. You can see this disaster shortened at 6 weeks post-op. And I don't know how to salvage that, truthfully, okay? So golden rule, don't sabotage your salvage procedure. That's something that I think I've learned since I've gotten here. You always have to be ready to revise your own surgery or other people's surgery. So here's a lady I did and just slowly got worse and worse after I corrected her, ended up fusing her MTP and she's now happy. I had to do her other side. but don't make this mistake. Thank you. So this is our division. We'll introduce more tomorrow, because our talks are tomorrow. Thank you very much.
Be judged. All right. Thirty seconds. Starts. Well, I'll use that one. Whoa. This is gonna be tight. Oh. 22 seconds. Oh, there's got to be some slant here. I'm not sure what it is. Huh? Getting tighter. 48. We have 8 seconds left. Any more votes coming in? Oh, 3, 2, 1. Oh. Good job, guys. Congratulations, Brown. Our last debate of the day is going to take Dr. James Brown against his mentee, Dr. Mike DePuzza, down at the University of Miami. He was a resident year behind me, graduated in 2013, and he's now doing total joints down there in Florida. So, Mike, good luck, and see if we can break the cycle. The cycle, 4 for 4 so far. So we'll see if you can break that cycle. Just press it down.
Okay, this one, right?
Yeah. Yep.
Okay. Hi, everybody. It's great to see so many familiar faces. My name is Mike DePuzzo. I'm from the class of 2013, and I didn't have in the cards that I was going to debate Dr. Brown this year, but here we are, and I only have 6 minutes to do it. And I want to start by saying that I'm not a fanatic. It's not like I do robotics for every knee, but I do think that the robot is like a tool the same way a mallet is a tool. And so if I think it's going to add value to the procedure, that's when I use it. And I find myself using it more and more. So I'm going to give you 5 reasons why I think using the robot in total knee replacement, it's a good idea. Reason number 1, probably the most important one, is improve accuracy. And we'll define accuracy as your ability to get your outcomes as close as possible. In this case, your post-op x-ray looking like your planning x-ray. All right. If you look at conventional total knee replacements and you look at all the post-operative x-rays, they tend to distribute in a very nice bell curve and with all the alignments clustering towards your goal. But as you can see here, I want to point out the number of outliers that you get when using conventional instrumentation. Not only that, I want you to see how far they move away from the cluster in the center. That's the magnitude of that inaccuracy. And so if you, that's just in one plane, right? That's in coronal plane. If you look at other planes like femoral axial position, in this study by Tom Ferry, you can see they only found 45% of their patients have 3 degrees or more external rotation, with everybody else having some degree of internal rotation. This is a study from WashU with surgeons from all different types of experience, with your target clearly identified in the center. You can see how 16% of those alignments fell outside of those goals. And even with high volume surgeons, 12% of those patients fell outside their target outcome. And this is true for every plane. In this, you can see here in this study how the robotic total knees, they cluster nicely around the goal. And you can see how the conventional total knee goes well distributed across all different types of ranges and how the magnitude of all those ranges are. And that's true for the femur as well as the tibia. Now, what Dr. Brown is going to tell you is that, well, who cares? There's no difference. Prospective randomized controlled trials have shown that there's no difference in outcomes when you use the robot in total knee replacement. And he's correct. Now, I have some concern about these studies, and I'm going to try to explain why. So at the top, you have conventional total knees. At the bottom, you have the robot. When you do conventional total knee, you aim for mechanical alignment, 0, right? And surgeons find themselves convincing to do some sort of functional alignment, and they usually use 3 or 5 degrees around the mechanical alignment because the robot is more accurate, so you can play with those angles a little bit better. Now, the issue is when you look at the post-op x-rays, this is what you get with conventional alignment. You have a wide distribution of angles. That's not what you're aiming for, which is much more reduced when you use robotics, showing that's actually a more accurate instrument to do this. Now, the comparison of the means of these two groups, I'm not too concerned, but I'm more concerned about what happened with these outliers. What happened with those patients that have 8, 10, 12 degrees outside? And we used to know what happened with those patients, right? We used to call it component malposition, but seems like that's not a problem anymore. Now, reason number 2, improve precision. And let's define it as, how close your post-op X-rays look to each other. And partial knee replacement is a great example to show this. We know that surgeons with high volume and high usage have lower failure rates and better survivorship. And that's because with the robot, you can get a perfect component alignment every time you use it on your first uni and every single uni that you do. Reason number 3, if you didn't use the robot for your uni, you get another chance when the uni fails, right? And so in this procedure, a conversion to a total knee replacement with the robot, because you're more accurate and you can plan your angles a little bit better, you really can plan for a primary total knee in many cases. And using primary components, we make a surgery that might be complex into an easier surgery with primary components. For the first case and for every single case. Reason number 4, you decrease the number of ligament releases that you do, as well as the need for using constrained components. And this is a nice case of a varus knee that a lot of times will require significant long amount of ligament releases with constrained components. But with the robot, you can actually use a primary component without doing so many releases. And that's true also for valgus knees as well as for varus knees. Primary components, no ligament releases. Finally, reason number 5, if you don't think it provides too much value for your patient, how about for the surgeon? We know that using robotics for the surgeon improves the physical stress with more physician satisfaction, less not only physical stress, but now we're doing some research that actually it affects cognitive decline much less if you use the robot if you don't use it. And we all know that a rested surgeon is a better surgeon. So I don't know if I was able to convince you that this is a good idea, but I'll tell you what, just follow your gut. If this were your knee, what would you do? Thank you.
All right, so I'm going to take the point here, the side that robotics have not improved the outcomes of total knee arthroplasty. I do have some consulting agreements with Enovis. None of them are related to robotics. So those of you who know Mike know that Mike's a great guy. Mike trained with us. He's become a good friend of mine. He's got a fantastic career. I love this picture of Mike that I was able to find. You see the concentration and how he's really, working hard to do a good job. And then you might happen to notice he's got a marker in his hand. He's still marking out the operation. So you see, Mike, it doesn't necessarily come easy to Mike, surgery. He has to really focus a lot and concentrate a lot on the basics. And so he just told you that his range of values in total knee is plus or minus 10 degrees. And Mike, you know what? If you're plus or minus 10 degrees on your cuts, maybe you do need a robot. So it is possible that you've convinced me that you at least should be, in fact, using a robot. I think the question really, when it comes to robotics, is robotics in arthroplasty just a fancy way of doing the same shit? Or is it really improving what we do? And that's, I think, the fundamental question here, right? So another way to phrase that, perhaps a little bit more eloquently, is have robotics demonstrated a causal relationship with meaningful clinical outcomes? And of course, I'm going to argue no. So the robot's been out in widespread clinical practice now for over a decade, right? We should have tons of evidence that the robot works. There's no question about that, right? A decade of use, we should have paper after paper showing the same thing. The evidence improves outcomes. And I will tell you that 10, 15 years in, there's not a single decent RCT that shows any difference in terms of robotics versus non-robotics, in terms of meaningful clinical outcome. Not a single paper. Now, there are a bunch of papers out there that you can quote and you show evidence. Mike managed to give a whole talk without evidence, which is impressive. That's not easy to do. But if you actually look at the literature and you actually pull up data and you use that to inform your argument, you'll find that there are multiple papers that will say, oh, well, robotics is better and it's better. And certainly Mike touched on some of those issues. The problem with these papers are that they typically deal with surrogate endpoints. Mike mentioned those, right? Your angles on a radiograph. What's a surrogate endpoint? A surrogate endpoint is an endpoint that the patient has no idea about. It's not important to the patient, right? The patient doesn't know if they're 3 degrees or 2 degrees. Nobody comes in saying, Mike, I like my knee, but it's at it's at 2 degrees and I know you're shooting for 0 degrees. That's a surrogate endpoint, right? It's not a clinically meaningful endpoint. And that's what a lot of these papers deal with in the literature, right? They're all angles measured on a radiograph.
The other literature that supports using a robotic is all based on observational data that is so heavily confounded to be useless. And there are plenty of those papers out there. There are a couple of meta-analyses just published within the last year specifically looking at non-surrogate endpoints, right? So looking at PROMs and so forth. And the bottom line was no difference. And in fact, some of these systematic reviews showed benefits to non-robotic surgery. So they all agree, all these papers agree on the same thing, right? We can all agree that robotics can produce more accurate looking x-rays, but it doesn't lead to better clinical results. And that's ultimately, I think, what I hope we all care about. The observational data is full of conflicts of interest and bias and confounding. We've looked at that here. We've done some research. Financial conflicts of interest in the robotic literature is massive. If you look at the odds ratio, so we looked at a study looking at robotics papers, whether or not the authors had a conflict of interest. And if they did, the odds ratio of that paper supporting robotics was 13.5. I mean, that is a massive odds ratio. So all you need to know about the literature is, does the author have a conflict of interest? If yes, then robotics look good. If no, then probably not. Some people will say, well, I don't need good quality RCTs to make a decision about whether or not to use a robot. I use the robot, it's great. I have less stress. I feel good at the end of the day. You know, robots are great. I love them. But the problem, that's sort of the parachute argument. Like, I know it's so good. I don't need the data. I just know. It's like if you're going to jump out of a plane, you don't need an RCT to tell you that you need a parachute, right? That's the parachute argument. Some things are just so good. I don't need the data. I just know it's good. And I've heard plenty of people make that argument about robotics. The problem with that, of course, is effect size, right? We all know that jumping out of a plane with a parachute, the effect size for survivorship, for your survival, is massive, right? It's massive. That is not the case with robotics. I think we can all agree that if there is a benefit to robotics and total knee arthroplasty, that benefit is extremely small, right? This is exactly the area in orthopedics where we need RCTs to know if something really works or not. And forgive me, but in arthroplasty, we've been led astray many times by a lack of good evidence, right? There's been new technologies, new implants, new techniques that have not exactly worked out well. So we're great at introducing new technology. We need to innovate, but at the end of the day, you've got to be cautious about things like robotics without good high-level RCTs, because all of these new technologies have risks, of course, right? And there are multiple studies now showing robotics increases OR time. What's the problem with increased OR time? Well, one of the problems amongst several is infection. And there are several papers now, including registry studies, showing that there may be a higher risk of infection when the surgeon uses a robot. And presumably, again, that's from time, perhaps all the other people in the room and the equipment and so forth. And there's a lot of robotic-specific complications that have been reported too: retained foreign bodies, burns, software malfunction, et cetera. And of course, cost is a big deal, right? It's $1 million to put a robot into your center. That may be changing with new models, but at the end of the day, there's a significant cost with this new technology as well. One of the other issues, of course, is the impact of robotics on future surgeons. Are we going to train surgeons appropriately? We now, when we interview for fellowships, have people coming to us saying, I've never done a knee without a robot. I'd really like to learn that. So in conclusion, we're going to skip this here, but in conclusion, I would say the current assertions that Mike makes about robotics improving outcomes relies on surrogate endpoints, hopelessly confounded data, or observational expert opinion. There's zero evidence at this point, despite over a decade of use, that robotics improve outcome, and really the widespread adoption has been driven by marketing and little else. So thanks very much.
All right, thank you very much. That was outstanding. All right, blow it up.
You guys slide up while you go.
So you 30 seconds to vote. It's only 2 votes so far. Mike, you can vote. You can vote for yourself. You get the robots voting for it. That's what you needed. All right, 10 seconds left. This is fun. So I appreciate all the guys who put together these talks have been fantastic. So thank you to all and part of the reason why we want to do these debates was to improve the engagement with alumni. I think we've done so in a lot. So congratulations to me. we're going to bring Aaron Casp up here to do the debate. So as we talked about yesterday, we do our debates, debate your mentor. And Aaron Casp is a resident here, graduated in 2020. Went down to UAB to do sports now. He's moved to, is it public news?
Yeah.
He's moved to Colorado to pursue sports in Colorado. So he's going to debate Dr. Brockmeier on massive rotator cuff tears. So the down buttons, how it works. Okay, you have 6 minutes.
6 minutes. Got it. All right. So I'm on the augmented rotator cuff repair side of this debate. Obviously, Dr. Brockmeier, world-renowned shoulder orthoplastic surgeon, is probably going to go towards reverse. So my goal for today is to convince you that you should try and repair the massive cuff with some sort of augmentation instead of jumping to reverse. And that also convince you that this guy should probably put the saw down, okay? So if Dr. Brockmeier tells you that he does not want to augment a rotator cuff repair, I will tell you that he is in fact on record saying that you should augment a rotator cuff repair, okay? So who are you gonna trust? Can you trust what this guy says? All right. So just for clarification, we're not talking about cuff tear arthropathy, proximal migration of the humeral head. That's just not what we're talking about. We're talking about this person shows up in their late 60s, had a cuff tear at some points, right back to the glenoid, right? Maybe some remaining tissue, partial type 2 tear, partial some tissue on there. Or what are you going to do with that? What are you going to talk to this person about? I would say that this is throwing the baby out with the bathwater. Okay, you're kind of getting rid of a lot of biology, and the cartilage is still good. And I would say the research supports that, literature supports that. So if you compare outcomes of reverse versus rotator cuff repair and those massive rotator cuff repair tears, you have a higher patient-reported outcomes, better forward elevation and internal rotation with the cuff repair group. There is a re-tear rate. I'll admit that. There's a re-tear rate, but you haven't gotten rid of this patient's biology. You haven't chopped out their humeral head. Massive cuffs. A lot of people are a little bit nihilistic about repairing a massive cuff repair, cuff tear. They're not going to heal. They're going to do miserably. They're going to lock them up in a sling. They end up with a reverse anyways. I would say the literature also doesn't show that. Even if you can only partially repair this rotator cuff, they're still going to significantly improve their outcomes compared to where they were before. A lot of times those cuffs don't come all the way over. They just don't come all the way over to the supraspinatus footprint where you want them to. So partial repair still does reasonably well. One newer technique is a biceps rerouting technique, which I have sort of employed a little bit more. Arthroscopically, you kind of pull the biceps out of the groove and put it more on top of the humeral head. It really improves that superior inferior glenohumeral kinematics in that cuff deficient or partially repaired cuff patient. It definitely improves outcomes in these massive rotator cuff tears that you attempt to repair. Forward elevation, external rotation, internal rotation, all better than just isolated repair themselves. And a lot of people will say, well, what about, you have a slap lesion. Why are you going to leave it attached to the glenoid if you have a slap lesion? It turns out it doesn't really matter. It's independent of a biceps labral lesion. And you're basically re-anchoring it at the top so that slap lesion is not seeing the force that it did before. How do we do it? Winston assigned me this talk, and I was afraid I wasn't going to have a massive. So this patient obviously does not have a massive irreparable rotator cuff tear, but this is how you do it. You basically pull it out of the groove, put it back on top of the humeral head, and then you just anchor it down at your medial row footprint. And there's some. What's that?
Can't talk to Steve.
Okay. And then your biceps is over there. What about this patient? You're looking at the glenoid. You have this massive retracted one. You're inside the joint looking up, and then you look up top and you go, uh-oh, there's nothing up there, some tissue left on the tuber. This is what we're talking about. This is the patient we're referring to. And then you go up top and you try and pull it over. It kind of reaches that articular margin. Maybe you can release a little bit more. It's posterior medially retracted. This thing's going to be tight under tension. So I've already released the groove here. You can mobilize that biceps tendon, pull it over the top, and then incorporate it into your medial row. And then repair it just like anything else, but just like any other massive rotator cuff repair, it's a cacophony of suture, right? You got 3, maybe 4 medial row anchors, and then you pull it over and it looks like the side on the right, and you're like, that didn't cover what I wanted it to cover. Never does. And these massive retracted ones. But then you can augment a little more. You just throw a nice little collagen patch over the top and you can't see it. It looks great, right? So overall, massive cuffs, even chronic ones can be repaired. Augmenting with a bicep rerouting technique really provides improved outcomes, saves the patient's native anatomy. You haven't chopped out their humeral head. You haven't gotten rid of any good cartilage. And, you know, this guy just wants to sell shoulder arthroplasties. Thanks.
All right. Do I get his extra minute and 5 seconds? All right. Aaron, excellent job. I'll get to argue for the reverse. Is it down button really? Oh, there you go. Thank you. So as Aaron pointed out, I'm heavily conflicted in this area. I will tell you, and you know, most people are like, here are my disclosures and move on. But I help a company as a consultant actually get royalties for designing reverse replacements. And as you pointed out, I also help a company as a consultant and get royalties for arthroscopic cuff repair with augmentation. So I feel like I'm perfectly balanced. In fact, I told Winston I had to argue either side of this one. So Aaron shows a picture of me apparently at P. Diddy's white party. And I show a picture of me and him hanging out in the back bowls of Vail. So Aaron Casp honestly truly represents the best of what we do here as our residents. He went from here up to Vail, learned from the guys there, and now is in an academic practice taking care of hard cases. So I'm really happy to be debating him on this topic. And I agree with many of the things that he said. That said, Ron, let's have some fun. All right. So first of all, rotator cuff disease. So, you know, in the shoulder, I'm not familiar with any other structure being called disease, right? So you hear about labral disease or AC joint disease. So this is basically an attritional process that happens to people as they get older, right? This is damaged tissue. This is compromised tissue. And so you always have to think about that when you're thinking about how to confront these patients, because the reality is you're not going to make that pitch better with an arthroscopic rotator cuff repair. So here's our guy, Aaron, back in his glory days when he's about to take on people. And when I see that, it kind of makes me nervous to come up and debate him. And so you'll see as he ages here, maybe that changes. So first of all, cuff disease is the most common thing we treat in the shoulder. It's a really common problem. Most are repairable. He said that, you know, we're not talking about these kind of straightforward cases, which is probably 90% of what we see. And most of those actually do very well afterwards. All right. The large chronic cuff tear, though, is a very different animal. And he showed you a couple of different ways you could try to conquer that short of doing arthroplasty. The final thing I'll say, and I'll talk about this a little bit in the talk, is that, you know, reverse TSA used to be the salvage operation they use in just the very old and very infirm because it barely lasted. But we're not talking about that anymore. All right, so here's Casp rotator cuff patient, right? So it's basically 65-year-old guy. You can see that on that's a chronic injury, right? Retracted, heads up on the MRI, not maybe up on the X-ray, but up on the MRI. Muscle is compromised, right? So high tide. So why is this so hard, right? So why are we trying so hard to try different things when frankly, we have a pretty good tool in our toolbox to treat many of these patients who are in their 60s, their 70s, their 80s with this problem, right? So there's all these different things that are out there that everybody's talking about and selling. So, you know, let's talk science here, right? So this is what's called the Rohe score. This was developed based on outcomes after rotator cuff repair to give you an idea of, and just like Dave talked about in the patellofemoral joint, these different variables that put you at risk for your tear not healing. I'll point out that Aaron showed a great study on augmentation where there was a 32%, I think, re-tear rate, right? So if you look at this Rohe score, you can see that kind of systematically drawn out. So older patients, larger tear size, more retraction, fatty infiltration of the infraspinatus, which you need to look for and is present a lot. And that's a negative prognostic factor. Bone mineral density, so these are older patients with thin bone, level of work activity. Simple math here tells you that if you had just a couple of these, it gets you in the 4 or 5 or 6 range. If you're at 5, a factor of 5, you got about a 70% healing rate. But that's your 32% people. Once you get to 6, it goes to 64. Once you get to 7, it drops to 32%. That's 32% success rate. And so you really need to think about these patients and understand where they go. JT Tokish gave this talk at the specialty day when I was program chair a couple of years ago with Dr. Miller's presidency year. So here's how you want to go through these patients, right? So you have your massive irreparable cuff tear. If they have DJD, you're going to do a reverse. If they're over 65, he contends you should do a reverse. If they're functional patient, meaning they lifted above 90 degrees, then you can consider some of these other things. If they're non-functional and the cuff muscle's dead, guess what? You're doing a reverse. And so you have all of these other options, but you really have to have certain patients to really consider using them. So here's Aaron's patient. Here's his repair, right? And that looks great. I mean, as best you can do with what you have. And here's that same patient 9 months later in your office with a repeat MRI, right? So if it's not going to heal, you can do whatever you want. All right, here's another Aaron case. So this is a female, same age, big cuff tear, right? So he's chugging a 40 and he's going to give this a shot. Number one, the best treatment for this patient is conservative management, right? So we don't operate on all these. These are patients that actually can do pretty well without surgery. But if you're going to do surgery, you can either do that or you can do that. And I'll submit to you, the second one probably does better. What about your intermediate options? So here's a patient of mine that I actually did with Aaron when he was a resident with us. And we decided, we got in there, it was not repairable. So we did this superior capsular reconstruction, right? And so here's what it looks like. Amazing operation, technically really fun to do. What are the indications for that? Well, you can see you want to be very diligent with your indications on when you do that. And the outcomes that were reported by the surgeon who basically came up with the operation were really illogically good. Here's that same patient. You can see it was back when Casp was with us because this guy's in his mask. You can see he's not smiling under that mask, I can tell you. Right? So these don't always do great. All right. Where you at, Ron? So what about a tendon transfer, right? So another intermediate non-arthroplasty option. Do I get his minute? So here's a good patient for a tendon transfer, right? Here are your indications for that. Key is no arthritis, anterior cuff has to be intact. There are those patients out there, they're few and far between. This is a 51-year-old. And what we did for her is this operation, a reverse replacement. What about data? There's great data out there on reverse in the rotator cuff irreparable patient population, not only short-term, but long-term outcomes. The pros and the cons are obvious. You want to keep the shoulder when you can, but if you're not going to be able to get it to heal, you should probably consider doing a reverse. What about longevity? So the initial reverses we did were kind of on the left there, right? So monoblock stem, high angle, you've seen notching, instability, all these complications. Here's a 2025 reverse with all of these technological advancements. So we have all these ways of doing this operation better. And frankly, these last. So these operations are good operations. In a 50-year-old, you worry for any arthroplasty operation. In a 65-year-old, it's going to do well. So Aaron walking off the mat, dejected here. Big chronic cuff tears are tough problems. These are tough patients. You do want to use an algorithm. There are certainly scenarios where you want to repair these. Reverse in 2025 is no longer a Hail Mary salvage operation, so definitely don't be fearful of using it. The data is there. And for the large retracted chronic and questionably reparable or irreparable tear, often it's better just to do the reverse replacement and let the patient move on with their life. That's it. Thank you very much.
Good. Perfect. Your phone's out. We're going to see who wins the debate your mentor.
What are we, 5-0 faculty?
The faculty currently are 5-0, so we'll see what happens here.
We're having the first one seat to lose to 60.
This is oh, God. All right.
Nobody's voting for anybody.
It'll take a little time for it to go. There you go. We have 18 seconds, 17. Come on. How about the underdog, guys? Oh, it's getting worse and worse. Move the needle. All right. Congratulations, Dr. Brockmeier. 6-0 in faculty. So Jesse Seamon was my night float junior way back in 2009, and now he's the big man down at Virginia Tech at Roanoke. So for those of you who don't know, we used to send our residents down to Roanoke. Jesse actually went down to PGY2 and loved it so much he stayed there for his career. And not only that, he started a residency program down there. So now he's a program director at Roanoke. Come on up here, Jesse. So Jesse is he's one of the legends of UVA, the Night Phoenix. If you look at his left shoulder, he's got a Phoenix tattooed there. So. All right, but you're up. You're going to debate your mentor. You've got 6 minutes to take down Dr. David Weiss, and maybe you can go 1 for 7 on alumni beating the faculty. We'll see.
This is an opportunity for all of you to prevent me from being the last alumni victim here. So I'm gonna try to convince you Weiss IM nails for supracondylar femur fractures. I'll pretty much just do that with cases that IM nails have significant advantages. We all know that they're biomechanically better, vastly superior in axial load, better with cyclical loading. The goal is to get all these people walking right away, and IM nail helps you to do that. It's an easy exposure. We can all do it. It's technically easier. Small percutaneous infrapatellar arthrotomy or bigger midline arthrotomy for more complex patterns, but it's more reproducible. There's less fuss factor. There's less fluoro. Much lower risk of catastrophic hardware failure. I've been in practice 10 years. I use IM nails for almost every distal femur fracture. You know, really the worst things I've had happen is screws back out. But plates can break like this, and when they break, there's no easy answer. And it's easy to span most of the femur if that's what you're into. But we'll also talk about some short nails at the end. Literature, no difference in union rates, but less blood loss, less OR time with nails, better post-op function in terms of early ambulation, less patients that require an assisted device at final weight bearing. And so you're essentially looking at equivalent union rates, but shorter OR time. And I think you can feel more comfortable letting them walk right away. We'll just do cases. 58-year-old male, bad fracture, bone loss, intercondylar split, comminuted. Might be tempted to plate this. Midline arthrotomy, clamp it together, a couple screws, nail, 6 months healed. 93-year-old, some diaphyseal extension, he's got a split. Again, arthrotomy, some screws, rod, 4 months walking, doing well. Another bad one, right? It's a pattern, recurring theme. See how easy it is to do it with the midline arthrotomy. Even these complex cases are a lot easier to put together that way. Here we go. 6 weeks walking. Here's another bad one, 79-year-old, segmental comminution. Another bad pattern. This would be a nightmare. Trying to fuss around with this with the plate would take you forever. It's a 45-minute case. We did use a locking attachment washer here. This is some of the new technology that's come along with these implants, is that now you have these locking attachment washers, which will help to give you a fixed angle construct, sort of lessen the anxiety about a screw backing out in these really bad bone patients. We let them walk straight away. She hasn't followed up yet, but trust me, she's going to do well. Here's a 60-year-old BMI greater than 50 patient, fall, far distal fracture, intercondylar split. Not easy to deal with. We did a nail, use a locking attachment washer. I did an arthrotomy so I could piece the joint back together across the split. And then you can also place like a small plate through the arthrotomy if you're worried about your fixation. It's really easy to actually place this kind of anteromedial plate just off the articular surface, which can work to sort of augment things, and you can let them walk on it right away. The final one I'll show is the 61-year-old female. She's had a prior fracture treated non-op. You can see she's got some pre-existing deformity. No easy answers here. I mean, you could certainly try to plate it if you have 4 hours, or you could do a nail. So I did a short nail, used a blocking wire. I would have done a long nail, honestly, but just couldn't pass the deformity. I let her walk right away. She had a screw back out. This just shows you I'm being honest here. So it's what happens. Yeah, screw backed out. I took that out in the office. It took 1 minute. Here she is at 4 months post-op, and she's fully healed or close enough. So conclusions, pretty much use these for all distal patterns. You don't even just have to do it because it's better. You could also do it because it's faster and it's easier. For exposure with the midline arthrotomy that we're all familiar with. Very low risk of catastrophic failure, equivalent union rates. I think things to watch for, sometimes you have to watch for significant malreduction. You just kind of have to be on the lookout. I'll use blocking wires, some other tricks to stop that from happening. I think short nails are probably okay, but there's no evidence. So you got to be a little bit careful when you're using the short nails. And then sometimes distal femurs fail. And so when they do fail, it's a lot easier to revise them when there's a nail rather than a plate. And then, you know, if you can't decide, you can always do both. That's all I got.
I just Chhabra guys, they're fancy, their PowerPoint templates are super fancy.
Keep it simple. Keep it simple. You know why? It's important. We don't want you distracted by some fancy mumbo jumbo sports talks and stuff. Just gonna keep it simple. All right. So some disclosures first. So here's Jesse, class of 2014. There he is. Yeah, it looks like it. Looks like it. Just he shaved. He was the first UVA resident in my tenure here to go into trauma. So I have a near and dear place in my heart for Jesse. He did a great job. It was really, it's really been fun watching his career, watching him blossom. He went to SLU for St. Louis University for fellowship and then came back to Roanoke. He's been there ever since. So he's really done a great job down there now as mentioned, program director. And so we're really proud of him. It's been fun watching him do that. So some additional disclosures. I do use nails on occasion. And despite the fact that he was an excellent resident, I'm going to cherry pick the literature and also feel a little bit bad about destroying him in a public setting, but that's the way it goes. So let's talk about distal femur fractures. How should you fix them? Well, plates are awesome. Look at this. They come in different shapes. They come in different sizes. They come in different materials. You can put them on all different places. They're fantastic. Nails are for dummies. Come on now. That's all you really need to know. But I sense perhaps a little trepidation. Perhaps you want some literature. Okay, fine. Fine, we'll talk about some literature, some systematic reviews. Here's almost 1,200 patients. Plates have fewer complications in reoperation, union rates equivalent. How about these guys? 719 fractures, lock plates versus nails, similar rates of union, similar rates of reoperation, but nails with a higher non-union rate, almost 2.5 times. Higher non-union, malunion rate. All right, what about these guys? Almost 500 fractures, nails versus plates. They looked at complications. 35% complication rate for lock plates, not great, but 53% for retrograde nails, so even higher. So better complication rate with lock plates. And how about these guys? So intermedullary nails versus lock plating for native distal femur fractures, not periprosthetics. Similar outcome for range of motion healing, but less malalignment with plates. So plates, better alignment, better reduction. Well, remember the distal femur anatomy is not straight. So nails work great in the diaphysis. When you start to get into the more proximal distal segments, now you have mismatch. Jesse mentioned that. So see the broad area down here in the metaphyseal region where these fractures occur is much different than these areas where you're going to fill up the nail. The concept of the pencil in a cup. You've got the nail filling the diaphysis up here, but rattling around in that metaphysis, particularly in those older patients with much less good bone quality. I'm sure the patients down in Roanoke all have awesome bone quality because they're really good bone health and they take care of themselves and have really good nutrition and nobody has diabetes, it's uncontrolled. But you've got these, metaphyseal regions. So you're going to end up doing all these extra things. These are blocking screws. You can kind of fill this up. You can, but you got to do something with that metaphysis for these fractures if you want to keep their alignment well. Okay. Remember, this is a bimodal distribution. You have those younger patients with a high energy, but much more commonly we see this older fragility fractures and these periprosthetic fractures. As more and more patients get knee replacements, there's more and more risk of fracture in that area when they fall. And that can really increase their risk. So, you can use a nail like Jesse showed. So you have this open box design, you have this nail, this is a short nail through there. Yeah, that's probably going to work. They're probably going to heal. Don't love the reduction, but it's probably going to be just fine, right? What about this one though? Nails don't fit through that one, right? That's a big stem that's there already. You can't use a nail on that unless you do something really, some kind of funky revision. What about the very low fractures? Okay. So we know that nails get an average of about 3 points of fixation in these fractures, whereas plates will get an average of about 6 points. So you're not going to get a lot of fixation in this very low fracture. You can put a nail in it, but your fixation is going to be very tenuous. And this is the hip, so you've got to put a short nail in. Now you've got 2 implants. Now you've got some problems with interface between them, or you have to take out some of these screws. We talked about this morning. This plate's probably been in there for 20 plus years. If you get these screws out, are the screws going to break? Are they going to be out of your way if you want to put a longer nail in and overlap these components? So you've got to deal with all those problems. You can put a plate anywhere you need to. Look at all these different designs. Look at all these variations in plate anatomy and plates for different parts of the anatomy. You can put it on the lateral side, the medial side, the anterior side, then start medial and go anterior and make a plate do pretty much anything you want to. You can put it in any place you need to. You can double plate. A lot of the studies that Jesse was looking at with earlier weight bearing issues, now we let people weight bear on these plates, particularly if they're double plated. So there's always a reason. A lot of the earlier studies don't suggest that people can walk right away on plates, but we've been letting people walk plates, particularly if they're double plated or have some sort of supplemental fixation. So you can get people walking earlier. It's not just on nails. Here's more double plates. Here's a lateral plate and an anterior plate. Put plates anywhere you want to. You can contour plate. This patient had a terrible deformity, had a malunion, non-union, and so we put both a nail and a plate with them, and you can contour that plate and sort of put it anywhere that you want to. So, in summary, nails do work, kinda. But if you're like me and you really care about anatomic reduction, then be smart, use a plate or plates, because who doesn't love anatomic reduction? I'll tell you who. This guy. Thanks. Plate draw.
Perfect one to close. Thank you guys so much. So, oh wow, Jesse's already getting some votes. I'm actually, I will say, huh? Yeah, this is the voting crowd has gotten a little smaller, so. All right. This is exciting. 23 seconds, 2, 1. Oh, could it be? Go. 13 seconds. Oh. Everyone vote. I think.